This is the diagnosis talk. My name's Sarah. I'm one of the physios from COPE, and this talk can be found on page 28 of your booklets, which will look like this in your handbook. These are the slides that we show on the pain management program. And we start by openly admitting that diagnosis for many people has been a stormy sea. The journey to getting their diagnosis, making sense of it, how they felt supported in that process, how they feel ongoingly supported and making sense of things and understanding what to do next is often complicated. And really, that's because medicine is not as neat and tidy as maybe we hope it will be. And we're going to unpack a little bit of that today, but we just wanted to start by acknowledging that this very talk is often quite provocative and difficult for people. And it may also say things that are different to what you might have heard before, or they might go against the way you've understood things. And again, we acknowledge that and would invite you to sit with it, to mull it over and come back to us if this is a sticking point for you in particular. So many people we meet here often have multiple diagnoses, or they feel they've had conflicting diagnosis. Some people say that I was given this and then I was told it wasn't that and it was this instead. Or some people come to us and say, well, I don't have a diagnosis. And again, they are difficult places to be. It raises levels of uncertainty. And many of us, to feel safe, to help our threat system to dial down, are looking for things to be or feel more certain. And often people look to their diagnosis for that. We've spent a lot of time on the program looking at this sensitized nervous system. Some of the signs that your system is sensitized are in this picture here. And for many people, chronic pain is a diagnosis in itself. Again, that is hard for people to understand. People say to us, it doesn't feel like a diagnosis. It feels like it explains what I experience. Chronic pain is a diagnosis in itself, where we can be confident through assessment process that the adaptations in your nervous system are the main reasons why your pain is persisting. And many people believe, I think, if I get the right diagnosis, people often say they, as in healthcare professionals, they will know what it is. And when they know, they can treat it and they can make the pain and the symptoms go away. And that is a very strong drive in many people, drive to get the diagnosis, because they hope and they believe that the other side of the diagnosis will be this certainty and things will resolve and they'll go back to living the life that they want to live. And we understand that drive. It's very common. I think I wanted to highlight in the purple box here that there's often a drive to find this specific cause. People use the word it. And as we've probably been exploring with you so far, pain rarely has one specific cause. Pain is multifactorial and it's complex. That doesn't mean we don't understand it. I ask people sometimes to consider our own understanding. If someone has insomnia and you ask them why they are an insomniac, they would probably say, well, there's a few reasons. But if people are saying they have lower back pain, there's often a more cultural expectation that we will find a cause, a structure, a tissue that is causing those symptoms. And so the diagnostic process will often involve consultations, sharing your experiences with healthcare professionals, decisions being made as to whether or not investigations are necessary or helpful. And that also gets difficult because the more we look inside our bodies, the more we see. And it isn't always helpful. Or what you've been told as an explanation about what's going on inside has left you feeling more threatened, more vulnerable, and it hasn't answered things in the way you hoped it would. So it's tricky waters. That's why we title this talk Stormy Waters. How did your pain begin? For many people, they have a mixture of things going on. Some people do have a clear-cut pinpoint as you can see here, the pin of this is the date, the time, the event. My pain started with surgery or an illness or an injury, and they can pinpoint exactly. Other people on this side here, maybe if you now have a diagnosis of fibromyalgia or hypermobility or pelvic pain or migraine, you might have had a different experience. Pain started and spread and changed, and over time things developed rather than this clear-cut start point. Many people we meet are in this middle group here, several events, and then there was often the accumulation of multiple factors and then kind of the straw that broke the camel's back. We've explained that everything matters when it comes to pain, the biology, psychology, social, and today's talk is particularly looking at those biological factors. But the key part is that for everybody here, however your pain started, whatever your pain experience, you are on a pain management program because you've been assessed in the COPE pathway, and we identified that this pain system hypersensitivity is likely to be a really significant part of why your pain's persisting. So let's zoom in today on that biology section of this picture. What type of investigations do healthcare professionals order? They might be x-rays, MRIs, CTs, blood tests, ultrasounds, nerve conduction studies, even surgery. So sometimes going in with a camera to have a look. That's often a word like endoscopy, laparoscopy. The word oscopy at the end of it is the looking. The tricky bit with any investigation is that they cannot see pain. And again, that's hard to understand. None of these tests, even when they test the nerve, they are testing whether a message can travel down through a nerve. Those nerve conduction studies cannot test whether that system is sensitized and reactive. Even in lower back pain, many people assume that there would be an identifiable structure. The research shows us that only 5 to 15% of the time is there an identifiable structural cause for something like lower back pain. The majority of the time, the causes and the reasons are again multifactorial, and the sensitized system is a significant part of it. It's tricky. When are scans good? When are they useful? They are useful to eliminate the nasties, eliminate significant tumours, cancer, infections, inflammatory conditions like rheumatoid arthritis. So when someone has the possibility of something that needs urgent medical attention, that if left unchecked would be really detrimental to your health and well-being, in those situations when your history taking and your presentation and your experience has led the professional to want to rule out the nasties, the scans are fabulous. And unfortunately, they're not so good at being helpful when you have long-term pain. This sometimes happens to people. They get told, well, there's nothing on your scan, and that might be delivered with a kind of that's a good thing. People say to us, well, that leaves me asking, well, then what is it? That doesn't answer my question as to why do I have this really challenging pain experience. Or they may have heard words like unremarkable. And again, these are words that are used in the healthcare profession, and how they land on the person who is hearing them. Nothing on your scan doesn't feel good for someone who's wanting to make sense of why they are struggling so much. And unfortunately, once we look, we tend to say, well, whilst I was looking, I did find. And the words that we often use to describe the findings that may well be incidental, they have a lot of power. We're going to go through some of these words that are often used. Words like degeneration, disc degeneration, facet joint, the little side joints of your spine. Words like spondylosis. When we ask people if they know what that means, they often say, oh yes, I've heard of it. It is the Latin phrase, term for arthritis in the spine. Again, using a Latin phrase is really difficult for most people because it's not a commonly understood expression. People may have a scan and be told they've got loss of disc height or dehydrated disc, bulging discs, disc prolapse and slip discs. We're going to talk about these in a minute. Or thickening in their ligaments, spurs, extra bits of bony growth, osteoarthritis. And in that consultation, as a result of looking inside our bodies on these scans, People may have words used to them like bone on bone or wear and tear. And again, I invite you now to consider those words. How do they land? The word degeneration for many people will tell us that that implies it's going to get worse. And it's going to get worse and worse. Degenerating, wear and tear, bone on bone. People say if they stop to think about these words, they feel threatening. As if they also feel quite disempowering. They feel like things are going to happen inevitably and there's not a lot you can do about it. And again, if we think about our threat system, this will be dialing things up from the very words that we're using as healthcare professionals. This is a famous study, often quoted by an author called Burkinji. In 2014, he took several research papers and they looked at the findings from 3,110 people who offered to go through a scan or investigation process. What they wanted was to have a baseline of what do people who don't have pain look like on the inside. That's why they did this testing. So as I say, more than 3,000 people went through a scanner. And these were the findings. Pain-free people. Have a look at your age group. Let me take 50 years, for example. By the age of 50, 80% of people are showing signs of disc degeneration. Now, that word degeneration would be better if we called it signs of aging in your disc. By 50, 80% of people are showing signs of aging in their discs. And I think what we often say when we are delivering this talk in person is that by the age of 50, you may well see signs of aging on the outside, grey hair, wrinkles, changing the elasticity of your skin, things gravitating south, as some people tell us. They, to many people, don't feel threatening. They are what we expect to see. They feel familiar. We see it in other people around us. And those age-related changes feel more natural and normal. Unfortunately, the words we use to describe the same process on the inside often leaves people feeling much more vulnerable, and it's much more threatening. This is what we know. The research has shown that people who don't have lower back pain, they also have disc bulges, disc degeneration, protrusions and facet joint changes. So the conclusion is that these are normal processes like grey hairs or wrinkles, and they aren't necessarily the reason why you have your pain and experience. Again, we started by identifying that this is complex and difficult because I think people expect the test to reveal the answer, and from there we can change things, and it isn't that simple. Therefore, it's important, the next part of this says that you are not your scan result. It is possible to have changes, significant changes on a scan, but have no pain. It's possible to have significant pain impacting you in great ways, and yet we don't see much on the scans. That is, again, a difficult concept for people to understand. And really, we have to stop and ask ourselves, will a scan be helpful? Is it needed? Is it necessary? And actually, it's more important often to treat the person in front of you and not the picture or the scan result. As we mentioned then, a lot of these findings on scans are the wrinkles of time on the inside and out. We're going to move on now to talk about your spine and those changes in your spine. This is a picture here. You can see the blue box is showing you where is the back of your body. These parts here, if you were to feel along your spine, you are feeling those parts. Here you can see is the front of your spine, what we call the body, and in between each of these bodies of your spine is those vertebral discs. In the back here runs your spinal cord. So as we age, what is normal? As we age, our discs can lose height, and as you can see here, they slightly bulge. A bit like if my car tyre was to lose pressure, it would slightly bulge and round. Again, this is normal, natural changes, but we call it a bulge. We call it degenerative disc disease. It isn't a disease. It is a natural aging process. And I don't want to keep saying the words to grate you the error. It is the healthcare professionals who need to really stop and think about the language that we're using and the impact it's having on people in front of us. So what strengthens those discs? What helps keeps discs in their tip-top condition? What is good for their health and well-being? Exercise activity, any. There is no silver bullet. There's no supreme exercise that trumps all others. The best type of movement and exercise and activity are the ones that you enjoy, and you are likely to keep doing. So actually, whether that's dancing or swimming or weight training or walking the dog, all of them, any of them are great to do. There's a picture here of somebody in space, because we've done a lot of studies on the discs and cartilage of people who travel to space where there's no gravity, because we realize how important it is to take weight and load and that impact on your disc and your cartilage. When you go to space and you don't have it, the astronauts come back and their discs have lost height and their cartilage is less healthy. There's a whole program around how do you keep that healthy when you're in space. But actually what is important to let you know is when the astronauts come back and they start doing impact weight bearing activities, their discs go back to being fit, healthy and strong. So for many people, if a disc is bulging, that feels a bit counterintuitive to have a physio here today say that actually taking weight through and doing impact work, even light impact work like walking, is really beneficial. Discs can get injured, and the words that we would use medically are a disc prolapse or a herniated disc. And what happens if you look at this one here, the purple jelly from, the purple jelly has leaked from the inside of the disc through that outer ring, and it is now causing an irritation around that nerve root. You may experience symptoms in your leg, sometimes referred to as sciatica. So it's common. This can happen, this disc injury. The research shows that what the body does very cleverly is it absorbs and it heals with scar tissue anything that it needs to in that area. The studies show that a year later, 60% of that material is often absorbed and it's healed naturally. Surgery is not always necessary and it's not always helpful. Our body does a great job of healing. There's a phrase that is my personal bugbear. I wish it would go away from the language that's used, is the term slip discs. If you look and if you study the anatomy, discs are actually anchored by ligaments and structures to the bones above and below them. They are bound in by ligaments and tendons and muscles. They are so anchored, they don't slip. It's a very unhelpful term to describe when that jelly has leaked that I mentioned in the slide before. Why am I so grated by it is because when people hear the word slip, they often and very understandably imagine their spine as this fragile, some people say to me, I think it's like a stack of plates and one's going to slide out. Or some people say, I feel like it's the jam in the donut, and if you squidge it, it's going to pop out. And that imagery, very understandably, can make you feel different about your spine. You no longer see it as this wonderful, flexible, robust, resilient structure. And understandably, people say, I'm cautious, I'm nervous, I don't want my discs to slip, I don't want to trap nerves. And so they shy away from doing those things that we know keep your discs healthy and strong. They shy away from twisting or lifting or bending or taking weight and load through their spine. Why does pain persist? Even when your body has done a great job of healing, it is possible that the system remains sensitized. And for many people that we meet, there might have been some injuries or healing that needed to take place. But when the pain persists, it isn't as likely to be because there is ongoing lack of healing. It is most likely to be that the system is remaining sensitized. The key is knowledge and evidence that our tissues are likely to be safer than they might feel. This oversensitized system is in a real protective state. This slide is to put across what we see when we go, when we do surgery and when we look at people's bodies. Nature has an amazing capacity to find a way. So if you have extra bony growths or ligament thickening here, what nature does, much as these roots have done on those floor tiles, it finds a way around it. And this is also summarised in this picture. This is a fallen over tree in Richmond Park. And the tree doesn't look like it did when it was upright. You can see the original tree that's fallen down. But something new and different and beautiful and strong and resilient and robust has grown in its place. And our human body is very similar. We find adaptations, we heal in amazing ways, and we might not look quite the same as we did, but that doesn't mean we are not healed and can be healthy and strong. So some people that we meet haven't had something like a specific injury or surgery. Maybe your diagnosis is fibromyalgia, hypermobility spectrum disorder, functional neurological disorder, pelvic or abdominal pain, chronic fatigue, migraine. And as I mentioned at the beginning, for people, their history would be a much more gradual developing of symptoms. We know with fibromyalgia, people often understand it as widespread body pain, but there is also a lot that is going on, a bit like this under the iceberg and the tip of the iceberg. People with fibro are often also navigating anxiety and brain fog, depression, dizziness, dry eyes, dry mouth, tinnitus or ringing in their ears, fatigue, headache, irritable bowel syndrome, IBS, memory challenges, irritable bladder. Often people think they have a bladder infection, they get it tested, there's not an infection, they don't need an antibiotic, and they can't really make sense of why do I feel like I have a bladder infection. What we know is that sensitized reactive system might be what's driving it, not necessarily an infection. Widespread joint pain, muscle pain, restless legs, particularly at night, rashes, sleep issues, vision problems, widespread pain, weight gain. So fibro is also a multi-symptom, whole body experience of challenges. It used to be a diagnosis of exclusion. So clinicians would rule out other things, and they would then say, I therefore give you a diagnosis of fibro. That has changed. Unfortunately, we don't move on as quickly as maybe we should do in the healthcare settings. And some people are made to feel that fibro is a bit of a, well, I didn't know what else it was, and therefore I gave you fibro. And that is absolutely not what it should be. It is a viable diagnosis. It has criteria that have to be met in order to get that diagnosis. And it should be a very understood, validated, and well-supported experience that people are navigating. We know from the research that the main driver around the fibromyalgia is also this central sensitized system. Hypermobility, for many people that we see, that's a piece of their picture as well. These are some of the things that you might experience if you have been given a diagnosis of hypermobility, either outside of or as part of your COPE assessment. And for some people, that is a piece of their picture. It's contributing to why they experience what they do. Functional neurological disorder, FND, again, another diagnosis that also has this sensitized system at its root. So what we now realise, and all the more so, this is where the research is taking us, is looking what might be the common things that are driving these long-term conditions like osteoarthritis, persistent pain, hypermobility, fibromyalgia, long COVID, chronic fatigue. And we are looking to that pain system hypersensitivity as one of the significant factors that's causing this long-term struggles and suffering. As we've been showing here at COPE, what we're looking at really is to look at what's dialing up that threat system and what skills and techniques you have to feel empowered to make sense of your experience, to be able to explain it to yourself in a way that maybe takes some of that sting out of the threat, that makes you feel more confident, that you can, and as time goes by, become more robust, resilient. You can step into a healthier, better well-being version of yourself. Let's talk a little bit about cartilage and osteoarthritis. Again, I felt it was easier to put this on a table because the old view of osteoarthritis, or OA as it's called, was very much it's only to do with the cartilage. We only looked at the surface of your knees or your hip joints, particularly thumbs. They're the main joints that we see arthritis in shoulders. Sorry, I'll keep naming them now, and spine. We thought it was only a cartilage problem. We put it down to a mechanical problem, and we use words like wear and tear. As I say, that really should be wear and repair, because that's what we now know. We said that it was caused by old age, it was overuse, we had a degree of it was inevitable. The future was there's not much you can do. We gave people the message it's going to get worse and you'll likely need surgery. And that old view of osteoarthritis really has been superseded by the understanding and the modern view of it. But again, it takes time for these things to filter through the healthcare professions and culture. The new view is a whole body process. There's an inflammatory component where the chemical soup is not quite as kind of refreshing as it should be. Many things affect arthritis, your joints themselves, but also your guts, your gut biome, your immune system, your stress, your thoughts and feelings. This is unusual information for people, that all of these can affect your arthritis, and therefore making changes in those areas can improve things. There's lots you can do. It can improve and it might not need surgery. That is the message that we should be giving. And this is a big part of it that we're now realizing. This overprotective, hypersensitive pain system is showing up, and a big part of osteoarthritis as well. We are finding out more and more, literally year on year, if not month by month. Our joints, there's phrases used, motion is lotion, use it or lose it. And what I wanted to speak about here was how do our joints remain healthy? What do they need? What is really crucial for joint health? And the main message that I need to impart is, if you look at the green lining on the inside of what's called your capsule that goes round your joint, that lining has, when you move, little openings open up. And through those openings, you release this amazing glycolytic serum, nutrient dense dinner. In effect, you release your dinner for your joints when you move, because the openings open up. I've put a picture in here of WD-40. What you produce is so much better than WD-40, but I'm trying to illustrate that the movement releases the fluid, releases that nutrient dense dinner. And as you move, you wipe this nutrition all over your cartilage. Your cartilage doesn't have the blood supply, so it doesn't get nutrition through the blood. It gets nutrition through movement and the fluid being released. So unfortunately, if people have understandably shied away from movement, or they've been told their arthritis, they're trying to protect those joints, the very cartilage that they're trying to protect is unfortunately becoming less healthy if they move less and they don't have that nutrient dense fluid being wiped over their joints. It becomes an unfortunate vicious circle. I've put a picture of a sponge in because that nutrition needs to be helped along its way to be absorbed. When you move, you release it. When you move your joints through their range, you wipe it over the surface, but we need now to help work it in. It's a bit like a sponge, that if we wanted to get the water right to the middle of the sponge, we would release and compress and squeeze that sponge. And so when you are doing activities where you take weight on and weight off of the joint, that is helping get that nutrition deep into the layers of the cartilage. So what do we need to do? We need to be, for our joint health, we need to be moving. Gentle movement, the sequence that you're learning at COPE, where you start turning your head and rolling your shoulders and twisting your top half. All of that, think of it now as giving your joints their dinner. And we very cleverly, hopefully, we've made sure that sequence uses many, many different joints of your body, because what we're wanting to do is release that nutrition, wipe it over the joints, and we're also getting you doing some exercises where you take the weight on and weight off, sitting up, standing up, sitting down, weight on, weight off. That's what works that nutrition deep into the cartilage. If we talk about bone health, the key messages around this are that as we go through life, we are always breaking down bone. You can see the bone here is this amazing honeycomb structure, light but unbelievably strong. We are so cleverly made. All through our life, we're building up bone, we're breaking down bone. We call it the turnover. And this little picture at the bottom here has a number 7 to 10 years. Every 7 to 10 years, you have completely turned over all the bones in your body. Isn't that clever? It's an ongoing process of building up and breaking down. As we get older, we tend to break bone down more rapidly. And so we need to be doing things that promote the bone growth. What are they? Particularly weight-bearing exercise. So swimming is a wonderful exercise for so many ways, but it doesn't help with your bone density and your bone health. You need to get in some weight-bearing activities. That might be dancing, that might be walking the dog, doing specific exercise that I mentioned, like standing up and sitting down. Everyday activities, crouching, standing up, sitting down, climbing stairs, they are all weight-bearing activities and they're great for your bone health. We also know that the stronger your muscles are, the muscles actually, when they tighten and when they work, they pull on the bone a little bit, and that little bit of pulling stimulates the bones to grow strong. So we need strong muscles and we need weight-bearing exercise for our bone health. The 4 pillars of health. This is the last few slides now. 4 pillars of health that we really need to keep on investing for everybody, not only people who are living with long-term health challenges. What are the pillars? Moving well, sleeping well, thinking well, eating well. If we keep on topping up those pillars of health, we won't go far wrong. They will keep us as healthy and strong as is possible long into our later years. The tricky bit, as we've mentioned a lot, is finding that sweet spot. Not too little, not too much, finding the sweet spot that's right for you, that respects that you have this hypersensitive pain system that is in protection mode. And we're trying to help you to do as this graph shows. Find that baseline, find your sweet spot, and very gently and gradually build up the amount that you do so that you get the benefits for your health and well-being. Thank you for listening.